Good afternoon, everyone. Thank you for joining us today. My name is Dr. Miram Velez-Bermudez, and I will be your moderator. I am a postdoctoral fellow and member of the Center for Healthcare Equity and Kidney Disease team at the University of New Mexico. I do health services research and have worked with patients across the kidney care continuum, and that has included living kidney donors in the past. Today's webinar, From Test to Transplant, how to guide living kidney donors through transplant evaluation and decision-making processes, includes presentations on the living kidney donor journey. It will highlight donor evaluation, testing options, and considerations. So before I introduce today's speakers, I want to take a moment and thank our sponsor. We are grateful to Quest Diagnostics, who supported today's webinar. To kick things off, allow me to introduce today's speakers. Our first speaker is Dr. Bhavna Chopra. Dr. Chopra is the Medical Director of the Living Kidney Donor Program, Medical Director of Solid Organ Transplant Inpatient Unit, and an Assistant Professor of Medicine at Beth Israel Deaconess Medical Center. She is also a member of the Harvard Medical Faculty Physicians. I would also like to welcome Shahzia Lakhani to today's webinar. Shahzia Lakhani is a Senior Director of Clinical Education at the American Kidney Fund. She previously served as Lead Advanced Practice Provider for MedStar Georgetown Transplant Institute. Shahzia practices as an acute care nurse practitioner in transplants. So first, let's introduce Dr. Bhavna Chopra.
Hello, everybody. I'm excited to be here. Thank you for the kind introduction, Mariam. As you heard, I'm Medical Director of the Living Kidney Donor Program at Beth Israel Deaconess, and taking care of kidney donors is my passion. And I'm excited to talk about the journey of evaluating a potential kidney donor and some of the testing that goes with it. So without further ado, I'm going to get started. All right, so we will talk about living donor outcomes. We'll talk a little bit about informed consent, a little detailed discussion on medical evaluation, which should include evaluation of the GFR, proteinuria, hypertension, assessment of kidney stones, infection risk, cancer screening testing, genetic testing, paired exchange programs. We talk about psychosocial evaluation, surgical evaluation, and donor follow-up. There's a lot to cover. I'm going to try to move fast, and I'll be happy to answer questions. Just a little historic perspective here. On the left here, you see a picture of Dr. Joseph Murray. He's also considered the father of transplantation. He was a surgeon who performed the first kidney transplant back in 1954, where a twin brother donated his kidney to his other twin. Since they were monozygotic twins and had the identical DNA type, they did really well without any immunosuppression. The donor lived till his 90s, and the recipient also lived a good, healthy 20 plus years after his kidney transplant. This happened right across the road from our hospital at Brigham and Women's, and carries a strong historic perspective in the field of kidney transplant. And I wanted to share that with you. Moving on, for those of you who are not exactly sure where the kidney transplant goes, I wanted to show this picture. As you know, that the native kidneys stay where they are. They are atrophic kidneys. Nobody takes them out. When the surgeons put in a new kidney, it goes in the right iliac fossa. The renal artery gets attached to the iliac artery, the renal vein to the iliac vein, and the ureter to the bladder. I wanted to go over a little bit about the outcomes of kidney donation. The first graph here on the left shows the number of transplants that have happened every year over the last 10 plus years. As you can see, the green line is the line of living donors. And for whatever reason, the number of living donors has not increased a lot over the last 10 years. Every year, we still do around 5,000 to 6,000 living donors a year. Deceased donors, on the other hand, have gone up a little bit, and there are several reasons for the lack of growth of living donation, but I think it just needs a little bit more education and a little bit more work to increase the numbers of living donors, because as you'll see in the next coming slides, living donor transplants are the best transplants that the recipients can get. It's pretty safe for the living donors, and they do fairly well. So we hope to increase the number of living donors by education and webinars as these moving forward. So on the right side, there's a graph showing the outcomes of patients who got a living donor versus those who got a deceased donor. And as you can see, the living donors do really much better than the deceased donors. The living kidney recipient outcomes are significantly better in patients who get living donor kidneys as compared to the deceased donor kidneys. As you can see here in the graph, the deceased donor kidneys are the kidneys in green, and the living donor transplant recipients are those in the blue. And the living donor half-life is over 26 years, whereas for the deceased donors is 14 years. So the living donor recipients do way better than the deceased donor recipients. There are several reasons for this. The recipients of living donors have much longer survival, much better graft function. They have a much lower dialysis vintage, and there have been several studies that have shown the longer a recipient stays on dialysis, the worse are the outcomes. Living donor surgeries can be done in a timely fashion in such a way that the recipients do not need to wait to be on dialysis and can bypass dialysis altogether. So that gives them a better survival advantage. There are lesser complication rates, lesser rejection rates, and since living donor surgeries are a semi-elective procedure, you can plan the surgery when the recipient is in their best of their best health and the donor is in there well prepared and ready to go. Hence, the outcomes of the living donor recipients are way better than that of the deceased donor recipients. The crux of the talk today is to focus on evaluation of living donors. In 2017, KDIGO put out the clinical practice guidelines on evaluation and care of living kidney donors. Majority of my discussion on medical evaluation is from these guidelines. The most important piece of when we start off the evaluation of a living donor, it's the informed consent. And informed consent has several sections, and we have to make sure that the donor understands and is able to complete each of these sections. It's important to make sure that the donor has the capacity of decision making. They are doing it completely voluntarily. The donor understands all the outcomes and the potential risks. There is the process of evaluation includes shared decision making. We have to ensure that the health information of the donor is protected and carefully handled. And we have to ensure that the donor completely comprehends and understands and is able to make a decision without any undue pressure or influence. Medical evaluation primarily includes measurement of GFR or glomerular filtration rate. It's essential to ensure that the donors who are ready to donate a kidney have a lot of kidney function to start off with, because after donating, they're going to give away half of where they started off from. So we better make sure that they start off with a big number. The one way of measuring their GFR is by blood work called creatinine. And with the creatinine, helps with creatinine, we are able to calculate the GFR based on a CKD EPI 2021 formula, which is the most recent updated formula, which does not use the race-based adjustments. We can also get a cystatin C measurement and a creatinine measurement. A combination of the creatinine and cystatin C gives us a little bit better estimate of GFR. But at the end of the day, the blood work that we are getting, a creatinine and a cystatin C or a combination, either way, is all are estimates. They are not very accurate in telling us exactly how much kidney function the potential donor has. So it becomes necessary to do a measured GFR. Measurement of GFR is primarily done by doing a 24-hour urine creatinine clearance or we can do a idothalamic clearance or a nuclear med GFR. If there is any asymmetry in size of the kidney, we want to make sure that not any of the kidneys is compromised, and we are not giving a very compromised kidney to the donor, to the recipient, or leaving the donor with a smaller kidney. So we always do a split renal scan to assess for the differential function of each kidney. So what GFR is enough? According to the KDIGO guidelines, anybody who has a GFR above 90 ml per minute is acceptable for donation. Any number between 70 to 89, we have to individualize. A number less than 60, they shouldn't donate. So at our center, we use a age-based cutoff in GFR, and depending if there's an older donor, a GFR of 80 or is also acceptable, and I'll go over that in the next slide. If there is asymmetry in GFR in the two kidneys, or the two kidneys are not exactly the same, there is some vascular abnormalities or urological abnormalities or kidney stones, we always leave the better kidney with the donor and use the affected kidney for the recipient. It's just fair so that the donor has a better kidney to be with. As I had mentioned earlier, we follow a age-based GFR cutoff at our center. If somebody is very young, a young potential donor between the ages of 25 to 34, we want to make sure that they have a higher GFR before they donate. So we keep a cutoff of 97 ml per minute. Whereas if there's an older donor and they're in the ages of 65 to 74, we are okay with even if their GFR is up to 80 or higher. Proteinuria, and it's very important to assess for proteinuria in these donors. Any protein leak is associated with worse kidney outcomes. We always check for proteinuria and albuminuria. This is done by doing an initial screen of albumin creatinine ratio or protein creatinine ratio when they come in for their initial medical evaluation. But we also need to confirm the amount of proteinuria by doing a 24-hour urine collection and of proteinuria and albuminuria. So all our donors get a 24-hour urine creatinine clearance. We add a protein and an albumin excretion rate on it just to better assess the amount of, to make sure that there isn't any proteinuria or albuminuria to be worried about. Normal urine albumin excretion rate should be less than 30 milligrams per day, and if it is that, that's acceptable for donation. Anything between 30 to 100 needs to be individualized, and based on the transplant center risk acceptance, people can consider. But at our center, we being a bit conservative and careful for protective for our donors, we do not take anybody who has an albumin excretion rate more than 30 milligrams per day. KDIGO says that any donor candidate with an albumin excretion more than 100 milligrams per day should not donate. Another important piece for evaluation is hypertension. Blood pressures need to be measured accurately at least at 2 occasions. So many times when we are sending our patients to get their 24-hour urine creatinine clearance and proteinuria, they also get a biometric screen which includes a blood pressure check, and that's a helpful way of getting those readings. We try to get if the hypertension history is not really clear and it's indeterminate, we can do a 24-hour ambulatory blood pressure monitor, or we can repeat standardized blood pressure measurements. Any normal, if the patients, donors have completely normal blood pressures, it's okay to donate. But in older donor candidates, if their blood pressures are very well controlled with a blood pressure less than 135/85 on 1 or 2 blood pressure agents, and they do not have any end organ damage, they might be acceptable for donation. So a donor who, say a 60-year-old lady on lisinopril, excellent blood pressures with no evidence of left ventricular hypertrophy, no evidence of eye changes, no other end organ damage, it's okay for her to donate a kidney. The decision to approve a donor candidate with hypertension is based on their demographic profile and transplant program's acceptable risk. So if a 25-year-old comes to me and he has hypertension well controlled on one medicine, I'd be careful in taking that potential donor. I would say no to that donor. Microscopic hematuria is also another concern that requires a very detailed evaluation, and we have a flow chart here. I'm not going to go through the entire chart, but basically the bottom line is if somebody has microscopic hematuria and proteinuria, they are excluded from donation. If they have microscopic hematuria and a potential genetic risk that could go along explaining that this is coming from the glomeruli, they should be excluded from donation. But with very careful assessment, if the microscopic hematuria is there and the urological assessment is negative and the kidney stone evaluation has been done and that's normal, you can consider them on a case-by-case basis, and maybe they might need a kidney biopsy before we proceed and say that they're okay to donate. Obesity is a big uh, factor that needs to be assessed carefully these days. In the current environment, obesity has become an epidemic, and we have to carefully assess who is able to donate and who's not. This is a graph here showing the SRTR data on the average BMI of people who have donated over the years. The pink line and the light green line are of patients who had a BMI between 18.5 to 30. So majority of the donors are in the normal BMI range between 18.5 to 30. BMI between 30 to 35 is also an acceptable BMI at several centers, but the extremes of BMI, the very, very frail with a BMI less than 18.5 or above 40 BMI are at the high risk area regions, and we try to avoid donors from very, very low BMI or morbidly obese BMI. It's required that we measure the BMI for all donors. Anybody who has a BMI over 30 should be individualized based on the demographic and the health profile and the transplant program's acceptable risk threshold. Donor candidates who had bariatric surgery to get to the acceptable BMI, they can proceed with donation, but anybody who's been through a bariatric surgery, they become at higher risk of developing kidney stones down the road. So we usually recommend them getting a 24-hour urine stone risk analysis to assess their potential risk of developing kidney stones in future. Talking about kidney stones, it's important to assess for kidney stones in all our donors. So when somebody has two kidneys and there is a kidney stone that's being formed and that stone is blocking the pathway of one kidney, there's this other kidney that can pick up function, and you can wait till that stone finds its way out, and that's okay. But when somebody has donated a kidney, they do not have that other kidney to pick up function. But if the stone is passing the pathway and it's in the ureter, it becomes like a urological emergency, and that stone needs to be extracted. Hence, we pay attention to kidney stones, and those who are at a very high risk of forming future stones, we are worried about accepting them as potential kidney donors. So anybody who has history of kidney stones, we image to assess the stone burden, and we do a detailed metabolic profiling to assess why they are developing kidney stones, what's the underlying cause. So we do a metabolic profile to make sure they don't have hyperparathyroidism, they don't have high uric acid levels. We do a 24-hour urine stone risk assessment to see if they are significantly hypercalciuric, or if there are conditions that suggest that they are at a very high risk of developing future kidney stones. And our decision to accept a candidate depends on what these results show. Depending on the metabolic evaluation, if you think this is fixable and they'll be okay in the long run, we accept them if they had 1 or 2 stones in their lifetime. But if they've had multiple stones and we think that they'll continue to have a lot of stones, then those donors are excluded. Infection risk. All donors need to get hepatitis, HIV, CMV, EBV, and syphilis checked. There are certain other infections that need to be evaluated based on their local regional epidemiology. Some of these tests are TB, strongyloids, trypanosoma, West Nile virus, histoplasmosis, and coccidiomycosis. If a donor is found to have positive for any of these infections, we recommend treatment prior to donation. But if depending on the type of infection and the degree of infection, we have to have a risk-benefit discussion between the donor and recipient before we proceed with the donation surgery. Cancer screening is routine cancer screening per protocol as guided through the U.S. The Preventative Task Force. Includes colonoscopy, PSA check, mammogram, Pap smears. All donor candidates who have any active malignancy should be excluded. Um, Donors who have had a prior history of cancer and were treated but are at a very low risk of transmission or recurrence, they may be acceptable on a case-by-case basis, but this requires detailed discussion between the oncology team and the transplant team before accepting a donor who had a prior history of cancer. Any kidney cyst, if it's a simple cyst, that's okay, but if it's a complex cyst, it needs urological evaluation. Coming to genetic testing, this is the new thing that new kid in the block, and it's something that has been discussed about among all living donor assessments lately. In 2023, AJT published these guidelines on genetic evaluation of all living kidney donors. And basically, it makes sense to do the testing, particularly when there is a donor who wants to donate to their loved one and their first degree family relative, and we do not have a clear understanding as to what happened to their own kidneys, and we are worried about a potential genetic risk. There's been data suggesting that living related donors have a slightly higher risk of having kidney problems down the road after donation as compared to unrelated donors. And that's just purely suggesting that there might be a slightly higher genetic risk which needs to be assessed. So if there is a known genetic condition that we are aware of in the first degree relative, we check for that genetic condition in the donor to make sure that they don't have it before they donate. In other situations where we do not have a clear understanding of what was the cause of end-stage kidney disease in the recipient and it's a first-degree related donor, we again want to make sure that we check for the risk of genetic diseases in such situations. Or donors who have family history of kidney disease in multiple second degree relatives should also get this genetic testing done. So there are two ways to think about it: whether you know about a gene abnormality in the recipient or you don't know about the gene abnormality in the recipient. If you know, in the first scenario where you know about the gene abnormality in the recipient, we focus on that particular gene testing in the donor. If the donor turns out to be positive with the same gene mutation, they should be told not to donate. But if the donor is negative, then we continue with the rest of the testing. Sometimes the gene testing comes back with these unclear significance, variants of unclear significance, then that requires a little bit more detailed discussion, evaluation with the genetic counselor, and so on and so forth. The other scenario where we do not have a clear understanding of what's wrong or what genetic condition is there in the recipient, then again we try to check for a gene profile in the recipient and the donor, to look for all the genes that are known to be associated with kidney disease in both the recipient and in the donor, and find out if there is any positive association. We counsel the donor not to donate, but if the test becomes negative, we say yes, you're okay to donate, but we always counsel them that we are not 100% sure that it covers everything. There might be things that we are not aware of, so this test is not the all be all, but regardless, it gives some level of comfort to both the donor and the recipient that their loved one is protected. APOL1 gene testing is also a new thing that came around in the last few years. Here at Beth Deaconess, Dr. Martin Pollock and his lab has done extensive research in APOL1 gene mutation and the lifetime risk of end-stage kidney disease. We know now that African people with African American descent who are homozygous with APOL1 gene mutation are at a higher risk of developing end-stage kidney disease, but we do not know how exactly the donors, if somebody who has these homozygous gene mutation, what would be their lifetime risk of developing kidney failure if they have no other concomitant risks, if their blood pressure is good, they're older in age, there's no proteinuria, and everything else is okay. What is their risk? It's not entirely clear. So there's a lot of research still going on in this field. We are all eagerly waiting the results of the Apollo trial, which is designed to answer some of these questions. But there have been other studies that have been reported to give us a some kind of a clinical guideline as to how to approach a patient who has APOL1 gene testing and the positive results. So who should be educated about this APOL1 gene testing? Anybody who wants to donate a kidney and says that they have some African ancestry should be educated about it. Who should be tested? If this person who is coming in front of me wants to donate a kidney is young, has mild hypertension, has lowish EGFR, and or has family history of end-stage kidney disease, I'm going to try to convince them that they should get tested for APOL1 gene mutation. When to test? This is not the first test I'm doing when they come through the door. I usually do the initial preliminary medical and psychosocial evaluation, and if we think that they're passing through all the preliminary tests, the APOL1 gene mutation is one of the next tests we like to do to make sure that they are not, at least they are not at high risk with homozygous APOL1 gene mutation. How to approach a positive result? Again, we don't have confirmatory data yet. It's usually a shared decision making. If it's a younger donor or somebody who has other risk factors like first degree family member with end stage kidney disease or hypertension or lower GFR, I advise them that they shouldn't donate. But I had a lady who was 65 years old. She wants to donate to a friend, and even though her APOL1 gene mutation was positive, she had excellent GFR, no blood pressure problems, everything was okay. We talked about it and we thought that she could donate. So, I mean, it's on a case-by-case basis. The costs of the tests are usually covered by the transplant center, and it doesn't come to the donors at all. Next, I wanted to quickly touch on histocompatibility, HLA typing. We need to make sure that the donor and recipient are a compatible pair, but sometimes the recipients may have a lot of antibodies and cannot accept the donor kidney because there's a high risk that they will reject that kidney. In such situations, there are these new paired exchange programs that have come around, which is an excellent way and a win-win situation for all. These paired exchange programs are set up where all the incompatible pairs, where there's a donor and a recipient, donor wants to give a kidney to the recipient but cannot directly give due to incompatibility. All such incompatible pairs are listed on a national database, and computer software runs a matching program. They'll identify a potential donor which is an acceptable match, and the kidneys get swapped. It's a great program. It's a win-win for all, and the recipient is able to get a living kidney in lieu of their donor donating to somebody else, and the kidney that they get is compatible to them. Nowadays, with the given advancements in immunosuppression, it doesn't matter if the donor is an unrelated donor. In some ways, it's protective and comes up with good outcomes. The paired exchange programs because of these paired exchange programs, the number of living donors have increased. This avoids the need for desensitization, but there are some disadvantages of paired exchange programs. These programs require a lot of logistic demands, like to ensure that the donor recipients are going at the same time. There is a wait that the organ is picked from the OR and it's transported to the other city or other state, wherever it needs to go. So it's a lot of logistic demands that need to be taken care of. And if a recipient's donor is not a O donor, they might have to face delays and wait a long time to find a compatible match for their recipient. So there are some downsides to it, but all in all, it's one of better ways to increase the number of living donors and help these potential incompatible pairs. We participate in a program called National Kidney Registry, and it has several other incentives or voucher programs that help increase the process and encourage living donation. Some of those are the standard voucher program, advanced donation. They provide remote donation and provide different donor protection services also to protect the donors for the expenses they might have to incur during the process of the donation evaluation and surgery and so on and so forth. Quickly, I wanted to touch on the psychosocial evaluation. It's important to assess suitability, motivation, and psych history. We want to ensure that the donors have sufficient support, ensure that they understand the medical impact and the emotional impact of donation. They are able to take the financial impact, and we have to watch out for some psychosocial contraindications. So what are the psychosocial contraindications? Ambivalence about donating. If somebody is unsure that they don't know whether they want to donate or not, I tell them do not donate. If there is evidence of any kind of undue pressure, they shouldn't donate. If there is a suspicion of illegal secondary gain, like a financial transaction under the table, they shouldn't donate. If they do not completely understand the informed consent and cannot check box all the things that we discussed about the informed consent, they shouldn't donate. Any unstable psychiatric conditions that need treatment, or if there is present substance use disorder, they shouldn't be donating. Surgical evaluation, real quick, includes renal imaging and an anatomy assessment. The surgeons discuss the surgical techniques such as laparoscopy or hand-assisted laparoscopy, robotic. Rarely we do them open anymore. Left nephrectomy is usually preferred because of the longer left renal artery and vein. If somebody has bilateral atherosclerosis or fibromuscular dysplasia, they shouldn't be donating a kidney. There are some peri-surgical considerations where we talk to the donors about the OR, the duration in the OR, the risk of bleeding, risk of reoperation, length of stay in the hospital, return to work, and pain and physical functioning. Majority of the donors always do really well and do not have any of these risks. The outcomes are extremely good. The length of stay in the hospital is 1 to 2 days. Return to work is usually within 6 weeks. And they, by 2 months or 3 months post donation, they don't even know that they had ever donated. They feel exactly the same as they were pre-donation. They do really well. Donor follow-up, usually within 2 to 4 weeks post-donation for a surgery wound check, 6 months, 1 year, 2 years, and then we after that recommend that they see the primary care doctor annually thereafter. I wanted to end by saying that donor evaluation is a complex shared decision where donor interest is at the supreme most important thing that we all focus on. The Transplant Center does an incredible job to do a detailed medical, surgical, and psychosocial evaluation. And I wanted to end with a quote which says, "It is when you give of yourself that you truly give. That is the gift of life." It's by Khalil Gibran. And I want to thank you, and I'll be happy to take any questions.
Thank you, Dr. Chopra, for a great presentation on the process for a living donor. I again want to thank everyone for being here and your interest in this webinar about living donation. So today we're going to talk about how we as clinicians, coordinators, or allied health professionals can guide patients through the decision to becoming a living donor. My name is Shahzia Lakhani. I'm a transplant nurse practitioner and Senior Director of Clinical Education at the American Kidney Fund. So whether they are donating to a family member or a friend or anonymously, our communication is very important and it matters. We'll walk through what to tell patients, what to expect with the testing process, how to introduce the transplant team, and tips for supporting patient-centered decision-making. We also want to navigate through the insurance and the financial questions that they will have and that they should know about, including some resources from the American Kidney Fund. So let's start with the basics. Talking to patients about what they can expect is one of the most powerful things we can do by normalizing the idea of getting tested without having a pressure to commit. I often say something like, getting tested doesn't mean you have signed up to donate. It just means that you're gathering information and considering it. Helping patients understanding that evaluation is a non-binding confidential process is very important. And it includes routine labs that Dr. Chopra had covered. There's going to be imaging, a psychosocial evaluation, EKG, and a conversation about timing. So as important as it is for a donor to be ready, it also has to be the optimal time for the recipient where they are in a healthy position to be a surgical candidate and ready for a kidney transplant, as well as reinforcing the donor's right to withdraw at any time, having a conversation about their motivations and concerns, reassuring them that they can stop or pause the process at any time and that they can make the decision. This will be respected and kept private. So next, let's introduce the transplant team to the patient, right? Many patients assume the care team for the recipient is the same for the donor, but the two are completely separate teams. The living donor team includes a donor coordinator who organizes the appointments and the education, a nephrologist and a surgeon focused only on the donor's health, separate from the recipient's team. And a donor can expect to have a social worker and could also have an independent living donor advocate or an ILDA who is there solely for the donor's interests. This team is legally and ethically committed to the donor safety and to make sure that they're making this decision freely. So you have to let your patients know that you'll have a team focused on just them. Even if they decide not to donate, their privacy and decision will be protected. So giving them direct contact information for the transplant center and encouraging them to reach out on their own is very important. So the donor's interest always comes first. So let's talk about decision making. Donating an organ is life-changing, and often patients feel pressure to decide quickly or to say yes out of guilt or obligation. There are a few ways to guide them. You can ask open-ended questions. So why are you considering this? What does this mean to you? Or what would you feel more confident in what would make you feel more confident in your decision? There is importance in validating their mixed feelings. So patients often feel proud and scared at the same time, and that's normal. So reassure them that ambivalence doesn't mean they're unfit to donate. It just means that they're being thoughtful about the process. And emphasize autonomy. So let them know this decision is theirs and theirs alone, and that they can change their mind at any time, even after starting testing. So discuss the feelings that they're feeling, as I mentioned, pride, guilt, fear, and pressure. But again, like Dr. Chopra mentioned, there should be no coercion or any thoughts of, any inappropriate reasons to be donating. You can use decision aids like brochures, videos, and one-on-one counseling to help them process this at their own pace as well. So we're going to talk about shifting to one of the most confusing parts for patients, insurance and costs. So there is some things that they need to know. The recipient's insurance covers the cost of donor testing, surgery, and the immediate post-op care for the donor. And the donor's own insurance is only really used for unrelated or future care. Despite this, many donors face out-of-pocket costs for travel, lost wages, and unpaid time off. That's where support programs will come in. It's always important to make sure that the patient is ready in terms of understanding what this means to them financially if they have questions about it, and ensuring that they are able to have their short-term disability and their FMLA papers filled out for work. Now, there are some financial support programs, two key programs that I want to talk about. The National Living Donor Assistance Center, NLDAC, helps with lodging and travel and meals, and in some cases, they can help with lost wages. The American Kidney Fund's Living Donor Support Program offers reimbursement for travel and lost wages, and also supports donors traveling for paired exchange or non-directed donation. So AKF provides guidance through the application process, making it less burdensome for patients. And there's more information on the kidneyfund.org/living donor website. But don't assume that a patient is fine financially. Connecting them early to a transplant social worker or coordinator can help them screen for assistance. And so the AKF Living Donor Assistance Program currently assists living donors who have provided a kidney to a recipient in Massachusetts, Washington, D.C., Maryland, Virginia, and parts of New York City. So funding from generous donors becomes available. AKF is committed to expanding the program to more areas of need. And so this will cover out-of-pocket travel, as I mentioned, childcare expenses incurred by living donors, and grants that are up to $2,500 per living donor. And living donor and the recipient financial information is not required. or considered when evaluating applicants for program eligibility. Some states and employers also do offer paid leave or tax credits, and so the social worker can give this information to the donor. So let's wrap up with some final thoughts and some tips. We want to make sure that we are a guide and not a persuader. So living donation isn't for everyone, and that's okay. Our role is to educate and not convince. It's very important to center autonomy. You can learn more without making a decision today is also a powerful message. Knowing your handoff points. So if you don't know the details of the donor program, make the referral to someone who does and to follow up. Living donation is a journey and not a transaction. So it takes courage, education, and support. As professionals, we can walk beside our patients as they explore one of the most meaningful decisions that they might ever make. Thank you.
Okay. Thank you very much, Dr. Chopra and Shahzia, for your presentation. So let's begin our Q&A portion. For the first question, as potential kidney donors move through the evaluation process, what is the most prominent concern from patients, and how do you address those concerns?
So, concerns of patients when they're moving forward with donation, I think there are a couple things that they are worried about. One is their long-term health. Are they going to be safe in the long run? Do they have a risk of kidney problems down the road, or will they have, if they have another medical issue, is there going to be something that they will be limited about? That's one of their concerns. But another big concern is also their immediate, how are they going to manage all the testing process? How are they going to take care of who's going to take care of their child when they are coming in for evaluation and when they are healing from the surgery? All the social and financial aspects that they have to deal with in the perioperative period is also another big concern. I think most of the times once we are able to alleviate their fear about their long-term outcomes based on their testing, because we tell them that you've done all this detailed testing, and our hope is based on these results and from what we know from the national statistics, you'll do well and your overall long-term risk of a medical bad outcome is low. And once they hear that, they're kind of satisfied. But I think their biggest challenge in the moment is how to arrange for all these things that they need to do around the time of donation, taking care of family members, their work, taking FMLA, the financial hit. I think that's difficult, and I think our social workers do an excellent job giving them all the resources. American Kidney Fund provides lost wages. I think that's a big comfort to a lot of patients who are going in through through this process.
Yeah, that's a great point because there's a deep desire to help a loved one, but still understandable anxiety about the surgical risk. And then potential impact on their own kidney function, insurance, and financial implications. And so, we try to address the thoroughness of the evaluation process because it's not just about the compatibility and helping the recipient. It's very important to know that we have access to resources for the donor. And so that will support them in alleviating that question, sometimes understanding what happens to their long-term health outcomes. Like Dr. Chopra had mentioned when she presented, they sometimes feel, pretty good just after some weeks once they're healing. So.
Okay, thank you. So both of you touched on this, but I want to dig a little deeper. So Dr. Chopra, you discussed many considerations for the donor nephrectomy surgeries, including parasurgical ones, which I imagine are part of the informed consent process with donor candidates. We know that these donors who follow through have to be healthy because they have to pass that lengthy evaluation process. We know that they're giving up something they don't need to give up. And we know that they're often highly motivated to help the recipient. So we expect those who follow through with donating are accepting the risks of surgery. However, there's some evidence in prior qualitative work that some donors may find aspects of their recovery or their post-donation experience unexpectedly challenging. So Dr. Chopra and Shahzia, in your experience, what are some common unexpected challenges that donors encounter, even when those issues were covered in advance? And how can transplant centers better support donors in navigating these challenges, either within the informed consent process in the standard follow-up care plan or beyond?
Great question. And I would take it in two parts. So I know you were talking about the donor recovery over time after surgery. We tell the donors at length about all the potential, hiccups they might have post donation. Many times when they come in through the door for the first day, they didn't know that it'll take like 3 to 4 weeks for them to recover. They'll not be allowed to drive. They'll not be allowed to lift anything heavy. They can't even carry a bag of groceries. They don't come in on the first day knowing all of this, but we educate them. We tell them all the details, but sometimes all this information that's given on the first day of their education process, by the time we are getting close to donation, some of it is forgotten. And it's but at the end of the day, some people have a harder time in recovery than others, but I would say majority do very well after a time span is over. I think one of the reasons which is more challenging for the donors is this is a cohort of very healthy people. They have many times not gone through any surgery in their life. This is the first surgery they are going through. So they do not know what to anticipate. They think that it's something minor, it'll come out of it in a day and it'll all be good. So their expectations, no matter what you tell them, is not completely, since there's lack of experience, they've never had this to them before, it's hard for them to understand what exactly it will involve. But I would say 99% of all the donors with invariable degree of time. Some people feel extremely good in 2 weeks, but the others will feel better in a month and others in 3 months. But at the end, after a period of time is over, they recover completely and are able to get back to their feet and do whatever they wanted to do without any limitations. Um, so I think it's just the two things is, despite the education we give, they forget. And the other thing is they've never been through any kind of a major surgery before. And this is their first experience, so they just don't know what they're getting into.
Yeah, I think the transparency goes a long way, but if they haven't experienced it, it's hard to relate what the words really mean until they kind of go through it. And so supporting them through the pain, the discomfort, is very important. And then supporting them through support programs. So transplant centers have support programs for donors at post-donation. And then if they don't know let's say that they are donating to someone that they don't know, eventually, potentially, that recipient may want to make a connection. And so there are ways to do that that might also help with their process.
Thank you very much for that response, both of you. So Dr. Chopra, in your presentation, you discussed how genetic testing is starting to be recommended as part of that standard evaluation process for donor candidates. However, some transplant centers have limited resources and may not have the financing to routinely offer services like genetic testing to living donor candidates. Both of you, do you have advice for healthcare providers working at these centers so they may still offer as robust of an informed consent process as possible, even when the full clinical picture cannot be presented to donors? And broadly speaking, what are strategies that can help support ethical decision making in resource limited transplant centers?
Good question. And the idea of doing genetic testing is fairly new, and it was this paper that came out in 2023 by Christy Thomas that in the AJT that kind of told us or explained to us the importance of genetic testing. We all knew it, but there was no easy way of doing it, so we weren't doing it. Now I think there are commercial tests available through different lab services where it's not extremely expensive. It is, but maybe not so much so that they have a set genome of X number of genes that are associated with kidney problems, and they check it on everybody. So they have a gene panel that they check this using this sequence, natural sequence gene testing, and the more they do it, the cheaper the technology gets. So it's not that expensive, and since it's now commercially available and you don't have to contact one lab that is doing a research kind of study, it is a little bit easier to do those tests. And the tests, when they come up, when we get the results, they give a detailed report where, even though I'm not a renal geneticist, I'm not a genetics provider, I'm not a complete, I understand some of it but not everything, but the way they give the report, it's quite complete. They tell you if it is a negative test or a positive test, and if it's a positive, how significant it is. And they also mention about these results which are of unclear significance, and they detail a little bit about those test results. So even if you're not a genetic trained provider, that report gives us a decent enough information to know whether it is safe for the donor to proceed or not proceed. And some of these commercial tests also provide genetic counseling to the donors. So, if you have questions or you are in doubt, you can reach out to those provider, the commercial test laboratories, and ask them to provide that genetic counseling help to the donors. I think it's becoming more easily accessible, so we are doing it. We still do it selectively, not on everybody. We do it only when we think there is a first degree relative who has end-stage kidney disease with an unclear etiology, and we don't know why and they are young, and we don't know why they had their kidney failure, and a brother or a sister wants to donate. Then I want to make sure that the brother and the sister are safe and do not have the similar genetic risk. That's the case we are checking it. Those are the people we are checking for. Um, so I think things are becoming more easier than they used to be.
Yeah, genetic testing is definitely more accessible. It seems to become more part of the transplant process. It helps the donor also have transparency that they don't have, variants or genetic predisposition to kidney disease, and it also helps them in the long term, when they're donating, that they'll be able to recover after, supporting their autonomy and informed decision making.
Thank you so much again for such a thorough reply. So, Dr. Chopra and then Shahzia, I would love for you to reply to Dr. Chopra's reply. So both of you highlighted many roles within the transplant team, including for the recipient and for the donor. Do you have any guidance for the providers watching on how to work together to ensure that the transplant donor comes first? So let's start there, and then we'll move on to gaps that the American Kidney Fund can potentially fill.
So, I think the process of evaluation of a donor and for a recipient, for that matter, is a multidisciplinary process. It's not like, the nephrologist, the surgeon, the social worker, the independent living donor advocate. We all do a very thorough assessment to try to understand what are the needs of the donor, what are the testing they need medically, surgically, and they get the required specialist assessment to make sure that it's safe for the donor to proceed for donation. At the end of the day, we all might do as best of a job as we want. I always tell my donors, I don't have a crystal ball. I can't predict the future. We do as best as we can to make sure that it's safe for you to donate. Now, what are the gaps that we are seeing at the moment, or things that we need to fill? I think in some ways it's just, and it's at center dependent, and I think there should be more education to increase the awareness that living donation is safe. I think let's start from there. Because as I showed in one of those slides, the number of living donors every year over the last 12 years is still about the same. We've seen over and over and over again, and we have said it over and over again, that it's safe for donors to donate. But I don't know why we still don't see a rising trend on the number of living donors. I think there is maybe lack of education. Maybe in the general public, there are people still worried that something wrong will happen to them if they donate a kidney. I think starting there would be a big process. People need to realize that it is safe for them to donate so that they feel empowered enough to move forward and then get the testing started. I think that would be the first step. Um, and spending more resources there would be helpful.
I agree. The deceased donor pool is limited, and so increasing living donors would really support decreasing the number of people who have to rely on dialysis during end-stage renal disease. So this is really important to be able to support living donation. I would add that having a donor be able to do all of their testing in between, a day or between 2 days is very helpful rather than potentially having to return multiple times. So there are many centers that allow a donor to be able to get tested and have them scheduled for all the things that they need within a day, if it's possible. If not possible, then to spread it, so that it's reasonable for the donor. It doesn't, cause them undue harm for, missing work, having to use time off and those kinds of things. That would really support a patient's journey and their ability to be able to donate. I recently heard a story just last week about a woman who was, being tested at two different centers because she wanted to give anonymously to someone altruistically who she didn't know, but she knew she wanted to donate her kidney. And she was able to get her testing done all in a day for the two separate centers, which was really, really helpful for her journey and her experience. And I think that also speaks volumes to not just the ability of the center, the resources they have, but, not every center is one size fits all, knowing, sizes and those kinds of things, but very important to try to provide that for the donor.
Again, thank you so much. Any final thoughts to share with healthcare professionals caring for potential kidney transplant donors?
I mean, I would say that there are several myths that are out there that people think that, oh, this donor has this and maybe they can't donate for this reason, and maybe they have that and they can't donate for that reason. But I always would like to say that, nowadays with the way we understand medicine and so many conditions are now very well managed and we have several nephron sparing agents and treatments. So, the general public would be surprised sometimes to know that, okay, he could potentially donate. So I just tell, if you are not sure, just go ahead and fill out your application, and we are there to decide whether, if it is safe for you or not. So there are certain conditions which are an absolute no, and I get that, but if you are not sure about it, there is no harm checking and trying, because everybody is trying to expand the envelope a little bit.
Yes. So keeping the donor's voice central in every decision is very important, and to make sure that you're supporting the donor with them when they're ready to move forward, checking in with them and communicating clearly, compassionately, and building a dialogue that's full of trust so that they feel safe. And remembering that living donation is not just a medical act, it's, deeply personal, emotional journey for them and for the recipient. So when we care for donors holistically, we honor their gift and to strengthen the entire transplant system, as we mentioned, with the donor pool and increasing awareness and supporting their experience.
Okay. Thank you so much, both of you. So for additional resources on kidney donation and transplant, please visit kidneyfunds.org / kidney donation and transplant. Next slide. For more information on the American Kidney Fund's professional resources, please visit kidneyfund.org / professionals and research. If there are any topics that you are interested in to support your patient care, please share it with us at professionaleducation@kidneyfunds.org. Thank you again to Dr. Chopra and Shahzia for your presentations today. They were wonderful, very informative, and thanks again to Quest Diagnostics for sponsoring today's webinar. Thank you for joining, and we hope to see you again soon.